Hey guys, today we're going to talk about the care of the patient with diabetes. This is chapter 64. The parts of chapter 64 that are not covered will be covered in 495 because they would be taken care of in a critical care unit. And so that's not the care of the chronic patient. So we're going to be skipping DKA and some other things in there. Our learning objectives are to prioritize evidence-based care for patients with common complications of diabetes affecting glucose regulation. Teach adult patients how to decrease their risks for complications. Apply knowledge, I hate it when he does that. Apply knowledge of pathophysiology to assess patients for problems associated with impaired glucose regulation. Implement evidence-based nursing interventions to improve glucose regulation and prevent complications. Teach the patient and caregiver about common drugs and other therapies used to manage diabetes and its complications. The staggering costs of diabetes. This is from diabetes.org or the American Diabetes Association. Diagnosed diabetes costs Americans $327 billion per year. The healthcare cost for Americans with diabetes is 2.3 times greater than those without. 1 in $7 healthcare dollars is spent treating diabetics and its complications. And over 84 million Americans have prediabetes. Diabetes mellitus, from now on you'll see it as DM in the notes. I may say just diabetes during the lecture, but we are talking about diabetes mellitus for today's lecture. Okay. For all types of diabetes, the main feature is chronic hyperglycemia resulting from problems with glucose regulation, including reduced insulin secretion, reduced insulin action, or both. In this class, we are looking at chronic diseases of the adults. The focus of this lecture, we're going to touch a little bit of type 1 just so that we can differentiate between the two, but the majority of our lecture will be on type 2. And please make sure you look at table 64-1. So first of all, let's take a step back. Glucose and insulin. Glucose stored as glycogen in the liver and muscles. Blood glucose maintained by glucose uptake by cells and glucose production by the liver. Insulin is the key that opens the cell membranes. It's needed to move glucose into the cells. Lack of insulin in diabetes. Without insulin, glucose builds up in the blood, leading to hyperglycemia. And it can be from a lack of production of insulin, which is usually type 1 diabetes. And it can be from a problem, excuse me, and it can be from a problem at the cellular receptor sites, preventing some cells from using glucose for energy. Type 1 diabetes is shown to have an autonomic destruction of the beta cells of the pancreas. This destruction can be caused by multiple genetic dispositions and is also related to the environmental factors. It can be rapid in some individuals and slower in others. Some patients may present with ketoacidosis as their first sign, where others may retain some beta cell function sufficient to prevent ketoacidosis for a short period of time. Treatment of type 1 diabetes. They they use insulin therapy. They usually monitor their blood sugar 8 to 10 times a day. They use carbohydrate counting and exchanges, and daily activities have to be a balancing act to maintain adequate blood sugar. Patients with type 1 diabetes require a basal insulin at all times. So his treatment is daily injections of insulin or with an insulin pump. Now, with your type 2 diabetics, you do not have the auto destruction of the beta cells. But what you do have with type 2 diabetes is insulin resistance, and or a deficit in insulin secretion. Most patients with this form of diabetes are obese, and obesity itself has some degree of insulin resistance. Those who are not obese may have increased percentage of body fat, often is associated with a strong genetic predisposition. Treatment of type 2 diabetes. In the beginning, the body produces its own insulin. They could be normal or they may actually be elevated. The insulin resistance may be treated with rate reduction and or pharmacological treatment. Dietary intake is a huge factor in treatment. But over time, if the patient does not reduce their weight or pharmacological treatment is not working, over time the pancreas gets tired of producing such large amounts of insulin, and often the patient may have to resort to insulin, usually in conjunction with oral hypoglycemics, because you have to remember with type 2 diabetes, their bodies are used to producing their own insulin. It's just that their bodies are resistant to it, so they aren't being able to unlock the cells to let the glucose in. Antidiabetic drugs are not a substitute for dietary modification and exercise. A lot of times patients with type 2 diabetes will think, well, I tried the diet, but it didn't work, so now they've put me on anti-diabetic agents. So therefore now I don't have to worry about my diet as much because I'm taking this pill for it or I'm taking this shot for it. And what people don't realize is that if they do not continue working on reducing their weight, reducing their carbohydrates, and increasing their exercise, then their pancreas is going to get tired out and they're not going to be making enough insulin to support their glucose needs. And so even though they're taking the anti-diabetic medications that perhaps is helping the insulin to unlock the cells to allow the glucose in, now there isn't a sufficient amount of insulin to go into that cell once it's unlocked. So that's where there's a misconception with people who have type 2 diabetes that if they're on anti-diabetic drugs that they no longer have to worry about their diet or with exercise. So let me reiterate that one more time. Anti-diabetic drugs are not a substitute for dietary modifications and exercise. Hyperglycemia in diabetes. Now, you have a problem with acid-base balance. You keep thinking you're going to get rid of that, aren't you? Like, we're not going to talk about it anymore. But it keeps coming back like a bad penny. So anyway, so now with hyperglycemia and diabetes, we're going to talk about the problem with acid-base balance. When you have a lack of usable insulin in the body, what happens then is the body has to turn to fat for energy, thus releasing free fatty acids. And what this does is it causes ketone bodies to provide even a backup energy source. Ketone bodies collect in the blood when insulin is not available. This leads to metabolic acidosis, usually with compensation. How does this happen? We have the absence of insulin causing an increase in the hydrogen ions and carbon dioxide in the blood. This causes the brain to increase the rate and depth of respirations to blow off the CO2. This is called Kussmaul's respirations. When the patients exhale the acetone, which, by the way, is a very distinct smell, it smells like rotting fruit. Sometimes the patient will actually say, I can't get this nasty taste out of my mouth. But they're blowing off this acetone. And when the lungs can no longer blow it off, the extra acid then drops the pH and decreases the arterial bicarbonate. So you end up with metabolic acidosis that's compensated because remember back when we were talking about compensation, it's a metabolic problem. And the reason it's compensated is because when it was partially compensated, our body was trying its best to get rid of those hydrogen ions and carbon dioxide by increasing the respiratory rate and the depth of our respirations to try to get rid of that extra CO2. But when our lungs are no longer able to blow off that extra CO2, that's when the pH will drop and you end up with a decrease in your arterial bicarbonate. And keep in mind, there are classic symptoms of hyperglycemia in all diabetics: polyuria, polydipsia, and polyphagia. Lots of urine, lots of thirst, and usually they're very hungry. Other signs and symptoms of diabetes is frequent infections, blurred vision, slow healing for cuts and bruises. They'll have a tingling or numbness in their hands and feet, recurrent skin, gum, or bladder infections, extreme fatigue and irritability, or unusual weight loss. Medical emergencies with diabetes are diabetic ketoacidosis and hyperglycemic hypermolar states. Those will both be discussed in 495. We will discuss hypoglycemia today, and we will talk about hyperglycemia, but we're going to leave the DKA and HHS until 495. But we'll talk a little bit about hyperglycemia and hypoglycemia today.